live in 3, 2, 1, and we are live. Please start.
Okay. Namaskar and good evening, everyone. I welcome you all for today's webinar on breast cancer, conference on recent advances in management of ER positive HER2 metastatic breast cancer with CDK4 and 6 inhibitors. I feel an immense pleasure to welcome Program Director Dr. Sandeep Bairwa, Consultant Medical Oncologist, Jodhpur, for the welcome and introduction. Over to you, sir.
Good evening all. Thank you, Ekta. So guys, we have gathered here to discuss some of the management guidelines regarding the advanced breast cancer cases. And now let's discuss about the BRCA testing and other markers in breast cancer patients. And then I will like to invite Dr. Aparna Dhar. She is head of Department of Medical Genetics and Genetic Counseling from Core Diagnostics. So over to you, Dr. Aparna.
All right, good evening, everyone. Whoops, I think I've done a mistake. Just give me 1 second. I just thought of the slide. Sorry. Okay, perfect. Can everyone see my slides?
Yes,
great. Thank you so much. Good evening, everyone. Thank you, organizers, for having me here today. So I've been given this mammoth task to speak on the molecular treatment landscape of breast cancer. So without much further ado, let's very quickly get started. And let's ask, why is profiling so important in breast cancer, especially in 2021, And some of the key lessons that we've learned and we've understood is that tumors can have different profiles that require different therapies. One target could treat multiple tumors like agnostic markers. We've learned that one target, one drug can actually lead to resistance. One target, one drug does not really inform you of all your other potent targets. And one target, one drug does not always give you the entire picture. Now, in order to discuss the molecular landscape of breast cancer, understanding the tumor biology is very, very important. So breast cancer patients are classified as per the ER, PR, and HER2 status, and the TNBC subtype constitutes around 15% of our patients with treatment options of chemotherapy. And, the HR positive disease constitutes around 70% of our patients, and hormonal therapy is the mainstay of treatment. And then we've got 15% that is each HER2 positive, where anti-HER2 therapy improves significantly the prognostic outcome in both early and the advanced setting. But honestly, we've moved beyond this intrinsic subtype, you've gone beyond this HER2 positives, luminal A's, your basal-like subtype, and you're starting to look at more genomic drivers. You're not just looking at the simple classification. We're looking for alterations in the PIK3CA pathway. We're looking at DNA repair genes. We're looking at resistance mechanisms in the ER signaling pathway, and more growth factor receptors like FGFR1, which could potentially allow us to have more targets that will allow us to personalize treatment strategies in patients with breast cancer. And this is becoming, more important to patients with with metastatic disease, because the molecular landscape is very heterogeneous. And as you can see on the slide, it's, within each of the subtypes of HER2, HR positive, TNBC, you have a plethora of different, somatic mutations that can occur. And again, if you look at the differences between early and metastatic, you can see that there are at least 9 driver mutations. You've got your TP53, ESR1, AKT1, your GATA3, which are more frequently mutated in the ER-positive metastatic breast cancers versus early. And metastatic TNBC also showed an increase in the frequency of somatic biallelic loss of function mutations in genes that are related to homologous recombination repair. And then you've got the metastatic breast cancer, which actually showed an increase in the mutational landscape and clonal diversity compared to early breast cancers. Now, the poster child for building molecular profiling treatment algorithms is lung cancer. So I've actually tried to do this with breast cancer. And again, this is a very simplistic view of patients with breast cancer. And this flowchart essentially alludes to the fact that you only have three biomarkers, ER, PR, and HER2/neu. It also assumes that these biomarkers stay static. And we know that when a patient, when a patient's tumor recurs, or when a patient has stage 4 de novo or on progression, these biomarkers are not static. And about 30% of our patients, ER, PR, HER2/neu, actually could have a loss of gain of function. And the third thing it also assumes is that there's only one pathway that is really dominant, which again, I'm going to show you that you really need to see different pathways that are activated to treat patients. So again, a very simplistic view of patients with metastatic TNBC, and chemotherapy was your treatment option of choice. And you can see the PFS decreases with each line of treatment. So if you look at the if you look at the tumor biology of TNBC patients, we know they're typically associated with the most prognostic outcomes. And as you can see from the heat map over here, that patients with TNBC, it is not as simple as we think. And even amongst the groups of patients, we see subtypes like luminal AR, mesenchymal, basal immune suppressed, basal immune activated. And among each of these subtypes, we have different treatment strategies, such as immunotherapy for basal immune activated subtype, PARP inhibitors for those with alterations in the DNA damage repair pathway. And then you have your immunotherapy combinations in your basal immune suppressed subtype. And of course, there's anti-androgen therapy in your luminal AR. So again, not a very simplistic view. And here's what I think is the optimal molecular diagnostic algorithm for our patients in metastatic TNBC. And you can actually target the defects in the DNA damage repair pathway, where PARP inhibitors, platinum therapy have very clear roles. You could target the inflamed phenotypes where immunotherapy has, where immunotherapy again has a very clear role. Then you've got the AR pathway. If positive, we have agents. If you have alterations in the PI3K pathway, we have AKT inhibitors. And last but definitely not the least, you've got the diagnostic markers like your NTRK fusions, RET, which we know is which has just got an orphan drug status. And there's so much more data coming out. There's work in the area of EGFR T790M for TNBC cases. So this is a forever evolving algorithm. And I'm very quickly going to walk you through the data I've used to build this. So the IMpassion130 trials for TNBC patients illustrated in the PD-L1 positive cohort, there was an improvement in the OS, and this is again, depicted in the Kaplan-Meier curves. Then you have TNBC patients with germline BRCA mutations, and we got the IMbrca and Olympia trials that again alluded to the fact that if you have a mutation in this biomarker, which is BRCA1 or 2, when a PARP inhibitor was given, you actually saw very nice separations in these Kaplan-Meier curves that was favoring the group of patients who received a PARP inhibitor. And here's interesting data from a phase 2 trial where TNBC patients received a combination of chemotherapy in the form of paclitaxel and capivasertib, which is a target for the PI3K pathway and is an AKT inhibitor. And what you see is a very nice, again, separation in these Kaplan-Meier curves, favoring the patients who were getting the combination of those, was favoring the combination versus those tumors that did not actually have an alteration in their pathway. And let's just look at the molecular diagnostic algorithm of HR positive HER2 negative subtype. And again, patients not only have ER/PR as potential biomarkers, but we also need to look at the different pathways, such as those that could acquire an ESR1 mutation, because we know agents such as aromatase inhibitors do not really work well. And you need to look at agents such as fulvestrant. Then again, you've got the HR positive, where defects in the DNA damage repair pathway where PARP inhibitor can work. This is what we get from the Olympia trials. And we've also looked into the AKT pathway, and then you've got those agnostic and those orphan drug markers. Now, in the HR positive cohort, and this is so very important, at least in my opinion, is actually understanding the tumor biology of the disease. And I do think that this should be the new norm of how we practice. And the reason being is that patients do acquire that, endocrine resistance. And you can see this very nice animation over here where you see patients who are endocrine resistant, who were endocrine sensitive, and their tumors have very, very small clones of ESR1 mutation, and you give them hormonal therapy. Now, about 18% will acquire an ESR1 mutation, around 13% will have a problem or a defect in the MAP kinase pathway, and around 19% of patients, will have some sort of mutation in the MYC pathway. These acquired genomic alterations eventually leads to endocrine resistance. Now, some somatic mutations differ between early and late, or metastatic breast cancer, and especially in an ER-positive cohort, in an ER-positive subtype. So one of the things that's been very interesting in the last couple of years is the identification and development of the tumors acquiring an APOBEC signature in high TMB. And I do think that this could be the future of being a potential targetable biomarker. And this was a very nice case study that was presented at ASCO 2018. And, this patient initially had, was actually an ER-positive patient, breast cancer in 2001, and underwent appropriate treatment for early stage breast cancer. And eventually there was a recurrence in 2010. And then you see here that eventually after multiple lines of therapy in 2015, an APOBEC high signature was found. And this was eventually treated with immunotherapy in the form of a combination of chemotherapy and pembrolizumab. And you can see the patient did respond. Again, it's still work in progress, but there's hope. This is a potential biomarker. Now, the SOLO-1 trials, we all are very familiar with it. The cohort of patients with PIK3CA mutations were treated with a combination of fulvestrant and alpelisib, which is a PIK3CA inhibitor. And again, you saw very good responses. And something that was important is that really it didn't matter if these were detected on liquid biopsy or tissue biopsy. In fact, from a diagnostic perspective, I can tell you the liquid biopsy was far, far more sensitive in calling out these endocrine resistance mutations as PIK3CA mutations versus a tissue biopsy. So I've said this before, you can acquire a HER2 mutation, right? So over time, we've seen this so much more in our patients with HR-positive breast cancer. And this was a phase 2 SUMMIT trial that looked at patients with HR-positive HER2 mutant breast cancer and gave them a combination of neratinib and fulvestrant. And these were, again, heavily pretreated patients. And the combination did result in a clinical benefit rate of around 47% and a PFS of around 5.4 months. But here's a slightly more tweaked and a personalized algorithm for HR-positive patients, which are treated with, standard of care of being aromatase inhibitors and CDK4/6. I'll just tweak it a little bit more, making it slightly more personalized. And I move on to the flavor of the season being PARP inhibitors. We've all been hearing about rucaparib, olaparib, and I very quickly want to draw your attention to a very important concept that we call a BRCA reversion. So especially in our heavily pretreated patients, BRCA reversion is essentially a phenomenon whereby the BRCA alterations have the potential to restore their reading frames and actually revert to their wild type sequence. Or what they do is they remove the initial deleterious alterations and restore at least partial BRCA function, and especially BRCA2 is more susceptible. So this was a very nice case study to help demonstrate this concept, where we had a breast cancer patient, ER positive, with multiple who had progressed with multiple lines of therapy. They did molecular profiling, a germline test was done. They got a BRCA mutation. She was immediately treated with a PARP inhibitor. She had a PFS of around 8 months. She progressed, they added chemotherapy, she continued to progress. And at this point, they did a liquid biopsy and it actually showed that a BRCA reversion had occurred and they had to change their mode of treatment, which means she was not going to respond to platinum chemotherapy and inhibitors. So we know that ESMO has actually come out with a scale of clinically actionable, of a scale for clinically actionability of molecular targets, which is specifically for breast cancer. And if you look at these level 1, level 2 incidence trends, they seem to be more looking at your HER2 amplifications, your germline BRCA mutation, PIK3CA, MSI, NTRK, ESR1, PTEN loss, and AKT mutations. And then we have a plethora of different targets, which has less incidence that supports it, but we still look at them as they are clinical trials that are investigating them. Now, when we talk about any sort of cancer, and especially when it's metastatic, we know heterogeneity, both inter and intratumoral, does cause a problem, especially when you're trying to trace those biomarkers in your patients. And one really good way to look at the genomic landscape is through liquid biopsy. And essentially what you're doing is that you're looking at the circulating tumor DNA, which is a somatic tumor DNA, which is being discarded into the bloodstream. That ctDNA is isolated and is being studied. And then obviously you also have your CTCs, which is circulating tumor cells, which are intact cancer cells that are circulating in your body. But due to paucity of time, I'm not going to be talking about them, and I'm going to be focusing for a little bit on ctDNA. Now, we can actually use liquid biopsy to help with our metastatic breast cancer patients, and we could actually use it to detect two types of resistance mechanisms. And this is what we very commonly see in our breast cancer patients. Sorry. One would be looking at the linear clonal evolution, which basically involves tumor cells where you have a temporal evolution, where one dominant clone, you lose that one dominant clone, and one of the less dominant clones actually becomes dominant over time, which again gets selected out by therapies. The second one is branch clonal evolution, where you have a spatial evolution in terms of divergence of different clones that happens, So what you essentially get is a mixture of different cancer cells resulting in resistance. Now, we can actually use liquid biopsy in various aspects of clinical practice. We can do for screening and recurrence. But again, recurrence detection, this is still very early stage and in a clinical trial stage, so we're not ready for clinical practice. So today we just primarily look at it from a metastatic perspective. How can I use it for, tumor profiling, monitoring treatment response, resistance response, addressing the tumor heterogeneity issue, and just overall longitudinal monitoring. Now, one of the questions I think we do tend to ask ourselves as healthcare providers is, what is the clinical utility and what is the benefit of actually looking at the ctDNA in a metastatic disease versus I've already done profiling on the primary tumor? And this was actually one of the key objectives in this MIRROR study, which was a breast cancer-centric study. And they evaluated the concordance of genomic variants in the primary tumor tissue and ctDNA in patients with metastatic breast cancer. And there were some interesting findings. 107 of the 110 variants identified in primary and metastatic were also found in the ctDNA, so a concordance of 97.2%, which is pretty impressive. 13 variants in metastatic tissue and ctDNA were not even present in the primary tumor. And ctDNA could actually, as we know from this, became a very robust platform and a reliable platform for us to apply it in our clinical practice for breast cancer. Now, in 2019, again, we had the SABCS. And 2019 at SABCS, we saw the results of the plasma matched trial studies, possibly one of the largest studies that looked at the ctDNA of, with patients with metastatic breast cancer. And again, over here, we were able to identify mutations. It was even able to call out those very rare AKT1, HER2 mutations, which are clinically relevant, from a response rate perspective, especially when they're matched with targeted therapy. This is something that could have been missed if it was just done on tumor testing. So again, it solidified why liquid biopsy was important. But for me, in addition to that, it also was it compared the sensitivity of liquid biopsy versus paired tumor tissue, and the overall sensitivity was around 93%. In fact, in addition, it also compared doing ctDNA on NGS versus ctDNA on ddPCR. And again, NGS liquid biopsy was far more superior than all of them. And it could actually be, this just helped further cement the fact that liquid biopsy can be used to call out and track those resistance mutations. So then the question is, can you detect these driver mutations, for treatment resistance early versus tissue? And again, a very beautiful study that was presented by Dr. Chandra Labhati from the MSK group, for an ER positive patient, IDC. And when they did a head-on-head comparison of when they did tumor, they did liquid testing. So let's just look at the ESR1. ESR1 was detected on the tumor in July 2015, whereas plasma DNA was able to call it out as early as February 2015. So I think this kind of proves the point that, especially for resistance, these liquid biopsies are a fairly good platform. Now, earlier on, when I showed you results of the SOLO-1 trial, where patients with PIK3CA mutations were treated with fulvestrant and alpelisib and had a good PFS, but the real question was that, are there other markers within this group of patients that could actually allow you to tease out those who would and who wouldn't respond to alpelisib? So this was a very nice paper that came out last year in Nature Cancer, and it looked at alterations in PTEN and ESR1 that could potentially promote clinical resistance to a combination of alpelisib and aromatase inhibitors. And what the author showed was that if at baseline you sequence the tumor of your patient, you would not see clinical benefit if there was a PTEN mutation or an ESR1 mutation. Now, you can't always acquire that mutation in a baseline tissue, so you may acquire them over time. And ctDNA actually helped pre and post to pull this out. The presence of, an ESR1 and PTEN mutation actually could indicate the resistance to a combination of anti-estrogens and PI3K inhibitors. Again, which has a better prognostic outcome where it comes to match therapy. So in the case of when everything is, when we're looking at metastatic disease, because it's so heterogeneous, what we saw was that, interestingly enough, and again, this was only for breast cancer, ctDNA actually had 84% where, was their rate of calling out actionable mutations versus tissue biopsy. And this was both done simultaneously, with 66%. So in metastatic disease, there is a higher possibility of calling out actionable targets on liquid versus tissue. And now very quickly, I just want to spend the next 5-7 minutes on talking about my favorite segment. And when we talk about BRCA testing, we talk about any genetic testing. It's very incomplete without talking about the role of a cancer genetics clinic and hereditary cancers. So we know that 5 to 10% of breast cancer cases are hereditary. And these are some of the key features, the red flags that I always request physicians to, that when you are talking to your patient, you are taking history in your clinic. If you see a patient who's premenopausal breast cancer, diagnosed with more than one type of cancer, multiple women in their family with breast cancer, male breast cancer, ovarian, family history of pancreatic, prostate, melanoma, TNBC cases. We have the Ashkenazi Jewish population, but those Indians who are coming, in the Indian, from an Indian concept, it's those who are ethnicity is Indian, from a consanguineous background. So if you catch this, please route them to a cancer genetics clinic, because it's extremely important today, in today's world of genetic testing, that patients that want, that patients, we usually wait for them, that when the results come, they get, when the results come and it's positive or it's a VUS, then they get transferred to a genetic counselor. And what it does is, it just unnecessarily makes the entire process very stressful for the patient, their families, they're anxious, and it can be so traumatic for them. So what I do and what I really urge is that, when you start seeing features like this, please route them. If somebody's under 50 diagnosed with any sort of cancer, especially breast cancer, please route them to your nearest medical geneticist or genetic counselor, so that we, let them walk the patient through a proper pre-test counseling. And why is this important? Because there are a plethora of genetic testing options that are available. Do you want a single gene testing, multi-gene? Do you just want it to be HPOC specific? Is there a known hereditary mutation within the family? And does it become so important for us, to get involved in the patient's journey upfront, to take a call at the earliest, so we're avoiding, unnecessary testing, unnecessary costs, and you're actually reducing the patient. Now, I just very quickly want to walk through what we do. It's essentially NGS is your platform of choice for sequencing, and for those large deletion duplications, we have MLPA. So, and again, there's a lot of testing options. And I think one of the key reasons I feel that physicians are getting, sometimes they get uncomfortable with multi-gene panel is that, okay, so I'm seeing so many mutations. I don't know what to do, I see these mutations. What do I do with these genes, and what's its clinical implications? And we're very comfortable with BRCA1, BRCA2. The guidelines are very well defined. And I think, again, this is where the role of a geneticist or a genetic counselor comes in. So very quickly, just to walk you through what we do in our genetic counseling clinic. So our sessions pre or post counseling is structured into 3 parts: assessment, education, and counseling, which I think is the most important part. So in a pre-test counseling, we basically we understand, why is the patient referred to us? What is their aim for this from this session? Do they have a family history? We try and understand their emotions. How are they coping with the news that they've been diagnosed with cancer? Once we get that understanding, and we kind of let them feel like they are guiding our clinic, they are in charge. While we are very subtly, obviously, in charge of our clinic, and we obviously want the information, we want to guide them, educate them correctly, we kind of give them, we empower them to feel like they are the ones running the show. And we educate them about, especially today with multi-gene testing, it's not just about autosomal dominant pattern of inheritance. If there's a RAD51C, and if it's a homozygous variant, there is a possibility of Fanconi's anemia, which is an autosomal recessive pattern of inheritance. Somebody could be a carrier for some sort of an ataxia mutation because they've got an ATM mutation. So there are a lot of nitty-gritties that go into, explaining these sort of testing. And in addition to that, we kind of prep them that, look, these are the possible results that you could expect from your genetic testing, and this actually reduces the trauma around it. Or we warn them that, look, if this is negative, as a reflex, I may have to run MLPA. So if a patient is ready, a patient is in a better understanding and can make very educated decisions about what are their steps forward. Now, in all of this, we also try and understand and learn about, their psychological dilemmas, their emotions, their reactions. Can I sense anger, anxiety, denial, disbelief? Are they mourning the fact as to why has this happened to me? Is there grief? Helplessness? Are they trying to conceptualize and intellectualize the whole situation and understand, give meaning to this? So we try and understand all that in a session and we address it, which in turn we realize actually reduces the stress of genetic testing. And once the results are there and we come in for a post-test counseling, we explain to them what is the implication of this report. How does the results of this report actually affect them? Is there going to be some extra testing required? Do we have to do some sort of surveillance management? Is there some sort of risk-reducing surgeries or any sort of prophylactics that is available? And after explaining all that, who are the family members who need to get tested? Once we're done with that, we again go back to see is that how has this result changed a patient's thinking of themselves? Like, do we see a change in perception? Is there a change in the family ecosystem? Do we see a couple that was so comfortable with each other, but there's suddenly a sense of, oh my God, you're carrying a positive mutation and you're going to give it to my children? Is there a sense of, are we seeing negative feelings coming in there? Are we seeing a broken marriage coming out of that relationship, or a sense of guilt that how did I as a mother pass this on to my child, especially when the mother is asymptomatic? So do we see a change in religious beliefs? Is there a search of meaning for those negative patients? Is there a sense of survivor's guilt? So there's all this that is happening in the background, and this is why it becomes so important to do this upfront counseling. Now, I very quickly want to draw your attention to the study from the Mayo Clinic, which was done in collaboration with Ambry Genetics. And what they found was that the trend is that multi-genes is starting to replace single genes. And when you just look at this over here, is that, and this is just the high-risk families, right? Not the moderate, low, the familial risk, but high risk. 48% had a BRCA1 mutation, 52% had another. They had your PALB2s, your ATMs, your checks, and look at those incidence rates. Those are pretty high. And as we increase our cohort of patients, the number of genes, obviously, accordingly, we get the number of genes increase. We get a better understanding of these genes. And today, be it NCCN, ASCO, SGO, ESMO, they all have very clear guidelines in the management and surveillance options. And these genes are now, again, getting further classified based on high risk, moderate, and the newer genes. And, these all have, and the newer genes are essentially that we know that those genes have some correlation with HBOC, but there's still studies going on. We're still trying to understand the incidence and the penetrance rates. If you just look at the high risk group, you have the option of surveillance, management, surgery. That's, the sliver of the pie chart I showed you earlier of just 5 to 10% being hereditary. Those are the patients that could actually benefit the most from this information, because I truly feel that we can actually make this disease preventable. And these are the guidelines which are very beautifully mapping out and saying that if your patient is positive, these are the risk percentages and these are the management surveillance options that is available. So you aren't going in blind looking at a report and saying, well, I found this mutation, I found this gene, but I really don't know what to do with it. And we also know genetic testing has a lot of benefits. Early detection is great, catch it early, nip it in the bud, well and good. Prevention, again, I go back to the 5 to 10%. That is, I know it's a very small number, but I'm an optimistic. And if you just look at it 5 to 10%, if in sheer volume of patients, you could actually be reducing a large cohort of patients of going through the trauma of being diagnosed with some sort of cancer. And that is your, that is your target population. While I know surgery is not everybody's cup of tea, But if you can just get patients to come in and do an annual mammogram, that's a start versus them not doing anything before that. Treatment options. I've already said this earlier. We know germline testing, while yes, it does have hereditary and familial implications, PARP inhibitors, we do know are very, very helpful in these setups. And there are also studies underway that are looking at the other HRR genes for breast cancers. And at the end of the day, you know, when families are empowered with this sort of information, they can make very good, informed, educated decisions about themselves and their reproductive health. So to very quickly sum it up, is that tumor biology is extremely important, irrespective of the ERPR HER2 status of your patients. The DNA damage repair pathway not only calls out those patients with high risk of malignancies, but I do think they help guide treatment options better. Beware of BRCA testing when tissue is an issue. Please feel free, especially in a metastatic setting, to use and feel comfortable using a liquid biopsy as an option. And whenever genetic testing is involved, please, I do urge you to recommend your patients to a cancer genetics clinic. And on that note, thank you so much for your patient listening, and I'm happy to field questions. Thank you.
Thank you, Dr. Aparna. Thank you for taking us on a beautiful molecular journey. I have a question for you.
Yes, please.
So, for example, if a non-metastatic breast cancer patient completed a therapy and now on follow-up, she has developed a liver metastasis. She was a TNBC to begin with, and now the clinician decide to go ahead with the somatic BRCA testing. This patient, what will be the best tissue to assess the BRCA status? Is it the previous breast cancer block, or should I go ahead with the fresh liver metastatic lesion biopsy?
So thank you for that question. As per my understanding, with TNBC breast cancer patients, we do prefer germline testing is for what we have the approvals. So ideally, we would do a BRCA germline. There is this misconception that the somatic tissue will catch the germline mutation, but that's not always true. There is a possibility that those certain deletion duplication, certain point mutations would actually be missed on tumor testing. So I do know that sometimes we want to look at the other genes, so that's why we prefer somatic tissue. If we are going to be going down the somatic path, I would take it from the new metastatic, like the liver biopsy. If it is accessible, I would prefer that versus the old. And the reason being is that when the disease started and versus where the disease is today, it's a very heterogeneous cancer. Breast cancer is also, especially TNBC, there can be a lot of changes that have occurred. So you may not see a BRCA there, but you may see a BRCA in the liver. But again, in breast cancer, it's germline. So ideally, you should see it irrespective of anything.
Thank you, Dr. Aparna. Thank you very much.
Thank you.
So guys, without wasting much time, I will move ahead with my part. That is about the discussion about the palbociclib in the advanced breast cancer setting. I will share my slide here. Are my slides visible? Can somebody show a thumbs up?
Yes, sir, your slides are visible, sir.
Okay, let's move. So these are my disclaimers. And as I discussed the epidemiology of the advanced breast cancer patients, the Globocon 2018 data has shown that the new cancer cases of breast cancer occupies 11.6% of all new cases worldwide. The incidence rate is number 2. The mortality rate of patients dying with breast cancer is 6.6% among all cancer deaths. This is the worldwide data, and in India, the breast cancer ranks number 1 in cancer incidence and mortality for both men and women. The 14% of it occupies 14% of new cancer cases diagnosed yearly, and the breast cancer in female patients it occupy 27% incidence rate. So the breast cancer landscape. Roughly 30% of women who have early disease will develop advanced or metastatic disease, and 6 to 10% of all women with breast cancer present with metastatic disease at the time of initial diagnosis. So hormone receptor positive, HER2 negative subset occupies 61% of the all breast cancer patients, whereas the TNBC subset occupies 15%. The hormone positive, HER2 positive occupies 15%. Another 15% of the breast cancer subset. HER2 positive subset occupies 9% of the breast cancer patients. The spectrum of metastatic breast cancer can be indolent and it can be virulent. The virulent presentation will be like there will be rapid development of metastasis. There will be very short disease-free interval, and there will be extensive visceral metastasis occupying in the liver, lungs. There will be resistance to the endocrine therapy, like aromatase inhibitor or steroid receptors degraders. The presentation can be indolent. The patient who are having a long disease-free interval, the patient who have a later on recurrence of metastasis while on endocrine therapy, the patient who are having bony tissue or lymph node only disease, the patient who are sensitive for the endocrine therapy. Now, the cyclin D1 and CDK4/6 are downstream of signaling pathway that lead to cellular proliferation and regulation of the G1S checkpoint. I will in this diagram, the CDK4/6 inhibitor cause detachment of the cyclin D from its complex form with CDK4/6. As soon as the CDK4/6 inhibitor get into the bloodstream at nanomolar concentration, the cyclin D get freed, and it cause phosphorylation. It cause the dephosphorylation of the retinoblastoma. As soon as the retinoblastoma get dephosphorylized, it get converted into active tumor suppressor form. The retinoblastoma is a G1S checkpoint. It acts on the G1S checkpoint. As soon as the retinoblastoma gene is activated, it doesn't allow cells to progress from G1 phase to proliferating and synthesis phase. The cells get stuck at the G1 phase. There is no tumor proliferation. So that is how the cyclin CDK4/6 inhibitors act. So for palbociclib, this is the first-in-class CDK4/6 inhibitor. It is an orally active selective inhibitor of CDK4 and CDK6. As I discussed, it inhibits the cell proliferation and cellular DNA synthesis by preventing the cell cycle progression from G1 to S phase. In a low nanomolar concentration, it blocks the retinoblastoma phosphorylation, leading into the specific G1 arrest in the sensitive cell lines. And already the experiment has shown that it inhibits the proliferation in cultured and xenografted leukemia, myeloma, breast cancer, colon cancer, and lung cancer cell lines. So palbociclib has over the years, there are many updated indication of palbociclib in the advanced breast cancer. For women's, palbociclib is indicated for the treatment of hormone receptor positive and HER2 negative locally advanced and or metastatic breast cancer patients, either in combination with an aromatase inhibitor or in combination with fulvestrant in women who have received prior endocrine therapy. In pre and perimenopausal women, the endocrine therapy should be combined with the luteinizing hormone releasing hormone agonist. For men's, the palbociclib is indicated for the treatment of HR positive, HER2 negative breast cancer, advanced or metastatic breast cancer in combination with AI as initial endocrine therapy, or with fulvestrant in patients who have received prior endocrine therapy. So as I move ahead, while discussing the global phase 3 trials, Paloma 2 was the first phase 3 study designed in postmenopausal patients who are ER positive, HER2 negative, having advanced breast cancer patients. These patients who has not received prior systemic therapy for advanced disease were included. The patients, the inclusion criteria were the patients who were having prior neoadjuvant treatment with anastrozole and letrozole were allowed if the disease-free interval was more than or equal to 12 months from the completion of therapy. The patients were having a measurable disease according to RECIST version 1.1 or having a bone-only disease. The performance status was ECOG 0 to 2. The patient should have adequate organ function, and there should not be an imminent or symptomatic visceral crisis. These patients were included and randomized in a 2:1 fashion between palbociclib plus letrozole combination, and the comparator arm was placebo plus letrozole. It was a double-blind study which was done at 186 centers in 17 countries. Treatment continued until objective disease progression, unacceptable toxicity, or withdrawal of consent. Interestingly, in this study, the crossover was not allowed. Palbociclib placebo dose reduction were allowed as per protocol. Letrozole dose reduction were not permitted. So as I discussed the demographics and the baseline characteristics of the patient in Paloma 2, 444 patients belong to the palbociclib plus letrozole combination arm, and 222 patients belong to the placebo plus letrozole arm. The median age while well matched in both the arms, it was 62. Most of the patients belong to PS of 0 to 1 in both the arms. In both the arms, the patients were well matched with visceral disease having in almost 48 to 49% of patients. Bone-only disease was found in 23% of patients in the palbociclib plus letrozole arm, and it was 22% in the placebo plus letrozole arm. Most of the patients were having 3 or 4 metastatic sites. The disease-free patient were stratified according to the disease-free interval, and disease-free interval can be below or equal to 12 months, or it can be 12 months. The patients were well matched in both the arms. So as I discussed the results of the trial, the data cutoff date was the February 26, 2016, and the median PFS in the experimental arm was 25 months, and it was 14 months in the placebo plus letrozole arm. The PFS hazard ratio was significant. It was 0.576, and progression-free survival assessment as done in the ITT population was also significant. It was 7.6 months in the experimental arm, and it was 14 months in the placebo plus letrozole arm. So in this forest plot analysis, the patients were analyzed and subgroup analysis was done. The addition of palbociclib gives relief, gives clinically benefit in almost all the subsets. Whether patient is having visceral disease or having bone-only disease, whether patient having a treatment-free interval of more than 12 months or treatment-free interval of less than or equal to 12 months, these all subsets get benefited with the addition of palbociclib. Even patients who are having a longer treatment-free interval, 5 years or more than 10 years, they also get benefited with the addition of palbociclib. Patients who are elderly less than equal to or more than 65 years or less than 65 years, these all patient subtypes get benefited with the addition of palbociclib and letrozole combination. So moving ahead, the investigator assessed progression-free survival in subgroups of patients. So as the Kaplan-Meier curve is showing, the progression-free survival percentage was more in the experimental arm, combining the palbociclib plus letrozole. The median PFS was 36 months, and in the comparator arm it was only 11 months. This Kaplan-Meier graph is showing PFS in patients belonging to bone mets alone. The progression-free survival in patients who are having a single disease site, the median PFS was 30.4 months, and it was half only in the arm belonging to placebo plus letrozole. So Paloma 2, the overall response in the intention to treat population, as initial therapy for postmenopausal ER positive HER2 negative advanced breast cancer, palbociclib letrozole improves overall response rate and clinical benefit rate over letrozole alone. The overall response rate in the experimental arm was 42%, and it was 34% alone in the comparator arm. Odds ratio was significant, 1.4. Clinical benefit rate was 84% in the experimental arm, and it was 70% in the comparator arm. Median duration of response was also more in the palbociclib arm. It was 22.5 months, and the placebo plus letrozole arm, the median duration of response was 17 months. As I discussed about the patients with measurable disease only, the overall response rate was 55% in the palbociclib plus letrozole arm, and it was 44% in the placebo plus letrozole arm. The clinical benefit rate also, as expected, is more in the experimental arm. It was 70% only in the comparator arm. The median duration of response is 23 months in the experimental arm, and it was 17 months in the comparator arm. So what about the follow-up of these patients? What are the first and second subsequent systemic anti-cancer therapies taken by these patients? So the patients belonging to experimental arm of palbociclib plus letrozole, during first progression, they received in 60% of patients, they received hormonal therapy. And the main hormonal therapy was fulvestrant, exemestane, selective estrogen receptor modulators, tamoxifen, and non-steroidal aromatase inhibitors. Another 37% of patients received chemotherapy. The various chemotherapy regimens as per physician discretion was allowed: capecitabine, docetaxel, paclitaxel, anthracyclines. The second during the second progression, the second subsequent therapy was hormonal therapy in 36% of patients in belonging to the palbociclib plus letrozole arm. Again, and there are usages of fulvestrant, exemestane, selective estrogen receptor modulators. Another 63% of patients were given chemotherapy as per physician discretion. So time to initiation of second subsequent anti-cancer therapies. So this graph is showing the event-free survival, and as expected, by causing the addition of palbociclib plus letrozole, the median event-free survival improved to 40 months, while the comparator arm belonging to the placebo plus letrozole was having a median EFS of 30 months only. So that means the event get delayed by the addition of the palbociclib. Time from randomization to starting of first subsequent therapy get delayed by the addition of the CDK4/6 inhibitor palbociclib. So the conclusions: After 37 months of follow-up, palbociclib plus letrozole consistently improved median PFS versus placebo plus letrozole in the overall population. It was 27.6 months versus 14 months, and across patient subgroups there was benefit of addition of palbociclib. Palbociclib was well tolerated, with the most common adverse effect being neutropenia and leukopenia. However, the overall incidence of neutropenic fever was low. It was 2% only. Even with long-term follow-up, the safety profile remained consistent with previous observations, and no new safety signals were observed. So palbociclib plus letrozole should be considered as an important first-line therapy option for patients with hormone-positive, HER2-negative advanced breast cancer patients. So now I will talk about the Paloma 3. It was a phase 3 double-blind study. The inclusion criteria were patient should have hormone-positive, HER2-negative metastatic breast cancer. Patient can belong to premenopausal, perimenopausal, or postmenopausal status. Patient who has already been progressed while taking endocrine therapy, either within 12 months of completion of adjuvant treatment or within 1 month after starting of treatment for metastatic breast cancer patient. The patient should have received one or less than one prior chemotherapy regimen for advanced cancers. The patients are randomized in a 2:1 fashion, and between the palbociclib and the placebo, fulvestrant was added in both the arms. The patients were stratified according to the visceral metastasis, sensitivity to prior hormonal therapy, and according to the menopausal status, whether pre, peri, or postmenopausal status. The primary endpoint was the investigator-assessed progression-free survival according to the RECIST version 1.1, and the secondary endpoint was overall response rate, overall survival, duration of response, safety, and tolerability. So this table is showing that the baseline patient characteristics were well matched in both the arms. The median age was 57 years in both the experimental and the comparator arm. The race, the patients belonging to white race, Asian race, or black race were equally distributed in both the arms. Patients belonging to pre and perimenopausal status comprises 21% of patients in both the arms. Postmenopausal patients were 79% in both the arms. And same was about the disease-free interval and disease sites. The patients were well matched. Interestingly, the 85% of patient has already been received aromatase inhibitor in both the arms. So Paloma 3, the updated data, as Kaplan-Meier curve is showing that with the addition of with the combination of palbociclib plus fulvestrant, the median progression-free survival was 11 months, and it was 4.6 months with the use of fulvestrant alone. This difference was statistically significant. And as I discussed about the subgroup analysis, this forest plot is showing that addition of palbociclib to the fulvestrant give benefit in all the patients, whether they belong to the premenopausal or perimenopausal status, whether patient have visceral or non-visceral metastasis. It doesn't the effect is more when there is visceral metastasis. Even patients having one or three or more than three metastases, they get benefited with the addition of palbociclib. Patients who has more endocrine sensitive disease, who has a disease interval of more than 2 years, they get benefited more. Although the patient the magnitude of benefit was less in patient who has a disease-free interval of less than or equal to 24 months. Patients receiving previous endocrine therapies, they also do better with the addition of palbociclib. Patients previously receiving aromatase inhibitor, tamoxifen, they all get benefited with the addition of palbociclib. Even with the patient who has a deleterious mutation of PIK3CA positive, they get benefited with the addition of palbociclib. So across the spectrum, across the subsets, the addition of palbociclib give significant clinical benefit to the metastatic patients. So Paloma 3, sub-analysis by the menopausal status. In this graph, the median the progression-free survival was assessed in pre and perimenopausal patients. So the progression-free survival was significantly improved in pre and perimenopausal patients treated with palbociclib plus fulvestrant and goserelin compared with placebo plus fulvestrant and goserelin, and it was consistent with the PFS benefit observed in postmenopausal patients. So in premenopausal and perimenopausal patients, the median PFS was 9.5 months, and it was 9.9 months in the postmenopausal women's. The differences was statistically significant with a p-value of less than 0.01 in the experimental arm, and it was less than 0.001 in the comparator arm. This table is showing the response rate in the Paloma 3. So the experimental arm in the intent to treat population, the overall response rate was 9%, 19%. And then the comparator arm, the overall response rate was 9%. That was clinically significant. In the population who are having measurable disease, the overall response rate was 25% in the experimental arm, and it was 11% in the comparator arm. The clinical benefit rate was, as expected, is more in the palbociclib fulvestrant arm. It was 67%, and it was 40% in the fulvestrant alone arm. Overall survival, and again, the palbociclib fulvestrant arm was the winner, and the median overall survival was 35 months in the palbociclib or fulvestrant arm, and the fulvestrant alone arm it was 28 months. So there was an absolute improvement in median overall survival in the palbociclib arm by 7 months. And as we dissect out further, the overall survival by sensitivity to prior endocrine therapy, patients who are sensitive to prior endocrine therapy, the median overall survival was 40 months, and it was 30 months in the fulvestrant alone arm. There was improvement of 10 months in the median overall survival. And in the population who are not having endocrine therapy sensitive disease, the median overall survival was 20 months in the palbociclib plus fulvestrant arm, and it was 26 months in the placebo plus fulvestrant arm. I think there is some discrepancy here. So the Paloma 3 conclusions. Palbociclib combined with fulvestrant significantly improved the median progression-free survival as compared with placebo plus fulvestrant as therapy in women with hormone-positive, HER2-negative advanced breast cancer who had progressed on one line of endocrine therapy. A median PFS of 11 months seen with palbociclib plus fulvestrant arm compared with the fulvestrant arm. Palbociclib was well tolerated with the most common adverse effect being neutropenia and leukopenia. Palbociclib in combination with fulvestrant is an effective treatment option for women whose cancer has progressed on previous endocrine therapy. The absolute differences PFS was 6.6 months with the palbociclib plus fulvestrant arm, and it was maintained for overall survival also. There was a 10-month improvement in overall survival in patients who are sensitive for the prior endocrine therapy. So important subgroup analysis. I will just say one thing here, that patients who are having comorbidities belonging to GI, musculoskeletal, or vascular or cardiac disorders. In all these subsets, in all these comorbidities, the median progression-free survival was prolonged with the addition of palbociclib, as we can see here. So median progression-free survival was, if I divide the patient across the age spectrum, all age patients, whether they belong to less than 65 year or they are elderly, 75 or more, they all get benefited with the addition of palbociclib. And progression-free, when I discuss the Kaplan-Meier curve of PFS among patients with measurable disease at baseline, the median PFS was 37.2 months in the experimental arm, and it was 27 months in the comparator arm. It was in patient who has achieved an objective response radiologically. When patient has not achieved an objective response radiologically, even in them, the median progression-free survival was 11 months in the experimental arm, and it was 5.6 months in the comparator arm. So palbociclib plus letrozole provided significant clinical benefit versus placebo plus letrozole in patients who are ER positive, HER2 negative, regardless of achieving an RECIST-defined objective response. Asian population, I'm just skipping this because across patient, Asian or non-Asian, the patient get benefited with the addition of palbociclib. So what about the prognostic and intrinsic subtypes and biomarker analysis in patients with bone-only disease? Again, I will also go through it quickly because patient having bone-only disease or visceral disease, they all get benefited with the addition of palbociclib. Patient-reported outcomes. So health-related quality of life index was more with the addition of palbociclib in across the spectrum of global quality of life, physical functioning, whether it's a role of functioning, emotional functioning, cognitive functioning, they all get better by the addition of palbociclib. And lastly, what about the safety data? If I talk about the all-grade side effect, the most common side effect was the hematological adverse effect, and the neutropenia was the major side effect. But interestingly, only 15% of patients developed the grade 1 or 2 side effect. Grade 3 or more adverse effect were seen in 55% and 10% of patients respectively. The other adverse effect were fatigue, nausea, and stomatitis. And when the patients were analyzed who has undergone a dose reduction versus a patient who has not undergone the dose reduction, the landmark analysis showed that the PFS was similar among patients who experienced dose reduction versus those who did not underwent a dose reduction in the palbociclib plus letrozole arm. So that's very interesting. So that means the continuity of therapy is more important rather than the dose intensity alone. Again, there was no differences if PFS was observed between patients who had one or more than one dose reduction because of neutropenia. I will quickly go through this, and I will just discuss this graph. So whenever the absolute neutrophil count of patients below 1000 was considered as a grade 3 side effect, grade 3 adverse effect, and the absolute neutrophil count below 500 was considered as a grade 4 hematological adverse effect. Grade 3 reaction, in grade 3 reaction, the advisory was to withhold the palbociclib and to repeat the CBC within 1 week, and to start the next cycle at the same dose when patient has recovered to less than grade 2. So the counts has improved to more than 1500. From day 15 of next subsequent to 2 cycles, The advisory was to continue the palbociclib at current dose to complete cycle and to repeat the CBC on day 22. It should be considered to dose reduction in cases where prolonged more than 1 week has been elapsed for recovery from grade 3 neutropenia, or there was a recurrent grade 3 neutropenia in subsequent cycles. Patients who are having grade 3 neutropenia with fever of equal to or more than 38.5 degree Fahrenheit or having infections or grade 4 neutropenia, it was advisable to withhold the palbociclib until recovery of absolute neutrophil count more than 1500 and resume the next cycle at the reduced dose level. And in the non-hematological toxicities, if there is a grade 3 or more adverse effect, it was advised to withhold until the system abates and resolve to grade 2 or less than 2, and to resume the drug at the next lower dose level. So I will stop here. I will just conclude by my concluding remarks. Palbociclib has changed the treatment paradigm. It has changed the treatment paradigm because prior to early 2015, there was no new treatment option for advanced or metastatic breast cancer patients who has been introduced to aromatase inhibitor. The long-term data regarding the effect of palbociclib on PFS, overall survival, and the efficacy of second therapy has been limited in that time period. What does all this data tell us? The palbociclib plus letrozole in first-line metastatic breast cancer patient has shown a median progression-free survival of over 2 years. The absolute differences median progression-free survival gain was maintained for overall survival, with a 10-month improvement in overall survival observed in patients with sensitivity to prior endocrine therapy. No evidence of specific cumulative or delayed toxicities with palbociclib plus endocrine therapy was seen. And as a final word, the palbociclib represents a substantial advance in care of HR positive, HER2 negative MBCs in the first line with manageable adverse events. It preserved quality of life for most patients with less and later use of chemotherapy. So I will stop here. And I suggest organizers, can we go ahead with the panel discussion now?
Yes, sir, you can go ahead with the panel discussion.
Okay. So we are having, so I will just a clinical scenario here. I have prepared a case. It is more of a hypothetical case. So if a 40-year female patient who is premenopausal and she started developing a red breast lump and found to be having a red LABC. It was hormone positive, ERPR positive, HER2 negative, and she has received neoadjuvant treatment, surgery, radiation. She was given tamoxifen, and she completed the 5 years of adjuvant tamoxifen. After completion of 1 year of adjuvant tamoxifen, she developed bone pain, and her CECT chest plus abdomen has showed multiple bone metastasis in vertebral column and in the long bones. So here I will start with Dr. Patik. Dr. Patik, how do you want to move ahead in this case? What additional history or diagnostic test will you do in this patient?
Yeah, good evening, sir. Very good evening. Sir, since she is a case like she is a 40-year-old female, now presented with metastatic cancer as hormone positive. So now, supposing that our performance score and everything is very fine. So the idea is for us to manage now this patient to be like a young patient with a good performance score. Like what we take in mind, a patient with good performance score reacts better to any kind of therapy that we give. Now, in this case, to go for a chemotherapy, it would be like detrimental to the patient, and we have other options in this case. So, as again, 40-year premenopausal, the first thing that we have to do is to go for an ovarian ablation in any case, whatever therapy we start. So I would firstly suggest to go for an ovarian ablation. And this, like, she has a bone mets, right? The bone mets respond very well to, again, that we have discussed that fulvestrant plus palbociclib therapies.
Very
So
nice.
surely.
Very nice. Okay. So I will ask my second panelist, Dr. Shweta Soni. Dr. Shweta, will you like to do anything else in this patient, in this case?
Sir, I totally, first of all, good evening, sir. Thank you for inviting me over here. Totally agree with what Dr. Prateek has mentioned, that first we should go for ovarian ablation, either by radiotherapy or maybe by LHRH agonist. And considering, sir, I just wanted to ask that the endocrine therapy, the patient was on tamoxifen and progressed like within 12. Was there a disease-free interval something in this case?
So she has progressed after 12 months of completing the 5 years of adjuvant tamoxifen.
After there was a 12 months of disease-free interval.
Yes.
So
yes.
in these patients, we can definitely consider for palbociclib and aromatase inhibitor after ovarian ablation. And as per the trials which we have discussed today itself, that in Paloma 2 trial, the disease, the median progression-free survival was almost more than 2 years compared to the placebo arm. So I totally agree with what Dr. Prateek is saying. And considering for the bone mets, we can also consider for palliative RT and some bisphosphonates for bone strengthening.
Yeah, that's true. That's very true. And I will ask with my remaining panelists, Dr. Chirag Soni. Dr. Chirag, will you like to do anything else? Will you like to do a PET scan in such patient? Maybe Dr. Tararam can answer this question. Dr. Tararam? Will you like to do a PET scan for staging purposes in such metastatic cases, de novo metastatic cases?
Sir, if I may ask.
Yep. Yes, please, Prateek.
Sir, even okay, if okay, this is the indication of PET scan. So suppose patient is not in any sort of visceral crisis. So will it make any difference? Okay, she has multiple metastatic sites, if we assume, and performance score is good, and she has no visual crisis. So will it change? We are taking a decision that you have to start her with AI plus palbociclib or fulvestrant plus palbociclib.
Yeah, true, very true. So it is not going to make any change in treatment. So that's why where where an imaging has already been done, there is no added advantage of doing a PET scan. So generally the PET is not advised in such ambitious breast cancer patients. So that's all I want to discuss today evening. If anyone have any doubt, any query, we can discuss.
So in case of, I have a question. In case of a visceral crisis, liver metastasis, extensive liver metastasis, or a patient with a brain metastasis. So which is the most appropriate CDK4/6 inhibitors should be considered for such patient?
Yeah, that's a good question. That's a very good question. In patients who are having a brain metastasis, The abemaciclib, the third CDK4/6 inhibitor, which has an intracranial penetration, is more advised. And although it doesn't have a head-to-head comparison with the palbociclib and abemaciclib, but theoretically, as we go in the science, it has better intracranial penetration. And the second thing, when the patient is having liver metastasis, now the thing is, how much is the liver metastasis? If the liver is totally compromised with the metastasis and there is jaundice, obviously you will go ahead with the chemotherapy. But if there is one or two or couple of liver metastases which are small in size and they are not threatening the organ function, then obviously I will suggest to add the palbociclib or a CDK4/6 inhibitor along with the combination of hormonal therapy. So very nice question. So if there are no more questions, I will wind up the session. Thank you, Dr. Aparna. Thank you, the organizers. Thank you, Dr. Batik. Thank you, Dr. Shweta, Dr. Chirag, Dr. Sirvi, and whole of the technical support team for making this virtual meeting a successful one. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you so
Thank
much,
you.
sir.
Thank you, everyone. And good night and Merry Christmas to everyone. Can we go offline?
Yeah, Merry Christmas.
Merry Christmas.
And yeah.